Hi everyone, I would like to welcome all participants to this webinar on the impact of COVID-19 on the quality and safety of healthcare and the lessons learned from it. COVID-19 has become a life and game changer in the whole world since the beginning of this year. But in fact, the disease started towards the tail end of 2019, and it was declared a public health emergency of international concern at the end of January 2020, and rapidly was declared a pandemic by the same organization on the 11th of March this year. Worldwide, many nations had to move rapidly to impose movement and border controls as part of public health measures to control the disease. Social distancing became a word everybody knows. The wearing of masks when going out became a norm. It was not looked upon as something unusual. Sanitizing was something that everybody was advised to do, and that had nothing to do with sanitation systems that we learned about in public health. I think the best quotation I've come across on this pandemic is from Donald Berwick. He said, "The severe acute respiratory syndrome, coronavirus 2, has only 15 genes, compared with 30,000 in the human genome. But it is a stern teacher indeed. Answers to the questions it has raised may reshape both healthcare and society as a whole. And I dare say it will reshape the accreditation landscape in the world in future." This webinar is organized by ASQua and CAHO. ASQua is an Asian regional grouping that was formed in 2008, as ISQua then looked upon spreading its reach beyond America and Europe in a more effective way. ASQua has grown from strength to strength over the years. It has remained one of the more visible regional groupings outside of America and Europe. A number of joint ASQua conferences have been held in this region before. CAHO is the consortium of accredited healthcare organizations. It is a non-profit organization. It comprises both NABH and NABL certified and accredited hospitals and labs, both within and outside India. CAHO's strength actually lies in these various training programs tailored for professionals in the healthcare industry, who are both in the public and private domains. The large number have been trained by CAHO over the last few years. CAHO also liaises closely with international bodies such as ASQua and ISQua, and within India, CAHO works with many government medical colleges and also QI-focused bodies such as the National Quality of Care Network. Their flagship conference is CAHOCon, which is a very well-attended conference, and they also run the CAHO Tech Conference in the same year usually. Today's webinar has a lineup of many eminent speakers. Professor Pa-Chun Wang, who is the CEO of the Joint Commission Taiwan, he will share his insights on Taiwan's perspective on the challenges faced by COVID-19. Dr. Lena Low and Dr. Michael Giuliano, who are executive directors of ACHS International from Australia, will share their expert views from innovations arising from COVID-19 challenges. Dr. Bhupendra Kumar Rana, who is the founding CEO of Quality and Accreditation Institute from India, he will share his insights on the role of standards in pandemic. He was also a former ASQua president. Dr. Hanny, Rono, he's the head of the international division. He will be from Indonesia. He will be presenting on Indonesian perspectives, challenges in COVID-19 pandemic, and we hope to have Dr. Sutoto, the chief executive of the Indonesian Commission on Accreditation of Hospitals, to join us. Dr. Atul Mohan Kochhar, he will talk on, he's the CEO of the National Accreditation Board for Hospital and Healthcare Providers, or NABH. He'll be talking on adapting to the new normal challenges and opportunities. And at the end of all these sessions, we hope to have a question and answer session which will clarify all your doubts on accreditation, healthcare system changes, and what are the challenges each country has faced on COVID-19. So I do hope that you have a very useful session. Thank you.
Okay, so everybody from ASQua, it's my great honor and pleasure to share with you how we are doing in Taiwan to cope with COVID-19 outbreak during these past few months. Actually, we are looking forward to grand reopen this coming weekend because we have been on the N95 seeing patients for more than 4 months, really drive us crazy. So I think the largest contribution is from the experience of the SARS outbreak 17 years ago. So we learned a lot from the SARS outbreak. During the SARS outbreak, many hospitals in Taiwan, they had to shut down because many healthcare workers, they got infected, and many young physicians and nurses perished during the pandemic. So when we learned that we had the first case in China and in Taiwan, we know that we need to secure our hospital, to secure the capacity of the hospital, so we can sustain the fight with the coronavirus. And also we need to secure all the medical resources supply. As you can see, that happened in many other countries. The PPE and the mask is a big problem. Okay, so I think the key steps for initial success in Taiwan is that right now in Taiwan is a professional that in charge to handle this whole situation. Not like in many other countries, politicians are in handle. And some other country, I mean, their management system are in chaos. But in Taiwan, we have a central commanding center, and that was established quite quickly, early in January. So all the orders coming directly from the commanding center. So everybody need to listen to the press conference 2 p.m. every day. So that provides us the most trusted information that calm down and stabilize the whole society. So every day, everybody listen to the minister of the minister's commanding center very carefully to see what's happening. I think keep the information transparent is very, very important. So I think that Taiwan did a very good job during the initial stage of the pandemic. And although we take a very different strategy of the screening, because there is constant debate whether to do the test for the whole population. But the situation in Taiwan is quite under control. So the commanding center, they insist they only do the test based on the criteria to a certain qualified candidate. So right now we don't do the whole population screen right now. And although we use a technology of IT to provide us the social distancing and the quarantine information. So I will talk to you later in my presentation. So firstly, we do the very quick border control, especially from China, because before the pandemic, between Taiwan and China, there are about 300 flights every day to more than 30 airports in China. Right now, all the connecting airports reduced to less than 5. So the border is strictly controlled immediately. Then we close our connection to other countries step by step based on the information we got from other countries. So I think that because Taiwan is a small island, so we have this advantage to control our border compared to other countries. They only have the land border. Right now, I can say we are a semi-lockdown or a soft lockdown. But right now we are facing a problem when to open, how to open, and open to what countries. But actually, initially, it's very successful. So we control the border immediately. I think that's the key steps of success. And the other question is the mask. Because based on the experience from SARS, we know we will have some shortage and panic buying of the mask problem. So government immediately increased the production of the mask. And they not only increase the production, but also to build many new production line and to secure all the material and the machine to produce a mask. So they estimate the demand every day is about 10 million masks every day. But right now, Taiwan's capacity, they can produce more than 20 million masks. So right now we have the luxury to export the masks to help our friends overseas. And although at the beginning, when we still don't have the enough mask supply, so the rationing of the mask is very important. So we used our national health insurance card to control the supply of the mask. So everybody, you need to show your card to go to the pharmacy or designated hospital to get your ration every day. So right now, during 2 weeks, everybody can have 9 masks every day. And although you can look into your mobile phone to see where are the nearby pharmacy stores, you can buy the masks. As I mentioned, information transparency is very important because the fake news is a big enemy during this pandemic. So Taiwan's government tried their best to keep the information transparent. I think the biggest contribution of the National Health Insurance Bureau this time is to provide the TOCC information on everybody's insurance card. So when you see a doctor, you insert your card, it will automatically show your occupation and whether you just came back from other country and where you come back from. So this is very important to help the physician to identify the travel and the contact history. And although you can use a mobile phone number to connect the insurance information and also immigration information. So we can provide a national alert to the citizens. And all the hospital and the department are on the, we call the reduced load mode operation. Because when you have all the mask and the protection gear, you cannot see so many patients. It cannot provide the service as before. So the hospital immediately shut down the visitors to the hospital. And everybody, when they go into the hospital, they need to check their temperature and check their insurance card to check their TOCC history. And although in the hospital, they streamline all the workflow to separate all the services, so the service line not cross with each other to reduce the chance of infection. And although we need to modify our sanitization SOP constantly, even though the principles are standardized, but your environment and your process can vary from hospital to hospital. So you have to adjust your SOP based on the new information. And the society, Taiwan, we are very lucky because right now we are the only few countries that the schools still run normally, and that all the stores, restaurants are run normally, even though their business are severely hit by the pandemic. But because the people, they need to keep the social distance. And we have the hotline, 1922. So if you see anything that's suspicious, and you feel you need to report to the government, you can dial the hotline. Somebody on that side of the telephone will help you. And although many schools, many hospitals, we have the virtual classroom and the telemedicine to help. And although everybody are asked to wash hands and have the mask on the public places. Okay, so there are many social gathering restrictions. We also have some challenges, you know, because in the spring, usually we have a large religious gathering, the Ma-Zu. Ma-Zu is the god of the southern east of China and Taiwan, is a lady god to help the fishermen. So every spring, they have a large gathering. So our commanding center successfully convinced the religious leader to postpone their religious gathering. So there are many challenges. You know, we need to change our lifestyle. We need to change our lifestyle. People have to change their style. There are many restrictions on the entertaining activities. So how about Joint Commission of Taiwan in this pandemic? Pretty much we cancel all our accreditation activities for this year. And within Joint Commission Taiwan, we conduct I'm Safe activity every day. So we monitor the health of our employees very diligently. So everybody need to report to their manager to see if there is any health problem. And although the hospital, we help the hospital to control the workload, and internally in the office, we do some control of our office space. And we open up all the teleconference options to our activities, because many of our surveyors and experts, they are from hospital, so they have higher risk to get infection. So we open up all the teleconference options to all the activities. And although the operation NOAH, we help the government to check the hospital readiness for massive community outbreak. So during this consultation program, we inspect all the hospitals to make sure they have their isolation wards and also the negative wards ready for massive outbreak. So they may need to take as many population communication infection case to their hospital. And although government mobilized a huge scale of the fund for the compensation of healthcare workers. So it's very interesting, because when I had a meeting with other colleagues overseas, many hospitals in Japan and in United States, they have a layoff plan, because many hospitals, they're facing financial crisis because lack of patients and reduce of the elective surgery. But in contrast, in Taiwan, government subsidize the hospital. They want the hospital to keep running. So our national health insurance, they lend the cash flow to the hospital, and they pay extra money to the healthcare worker, including the janitors who take care of all the infected case. And JCT's president, Professor Lin, he also wrote a letter to all the PGYs, because JCT are in charge of the training of all the PGYs in Taiwan. So we encourage them, they need to take this chance to learn. They need to prepare themselves to lead for next pandemic. So this is a once in lifetime opportunity for them to learn. And although as head of this organization, I watch the financial status of JCT very closely, because many projects have been canceled. We may face some financial problem. As you know, Taiwan is very strong in research and innovation. So during this pandemic, Taiwan's hospital and medical schools, they have many research innovation to cope with a pandemic, including the vaccine, medicine. We also participate in the remdesivir global research that shows a pretty good result. And although we have many invention for the screen and the intubation, although the telemedicine right now it seems very, very useful because you can reduce the contact between the healthcare worker and the patients, and it can reduce the consumption of the PPE. So the telemedicine solution make great sense during this pandemic. And right now, we are living a so-called new normal life, because not like in SARS outbreak, it's not likely the coronavirus will disappear spontaneously. Right now, it's only the intermission. And we are not safe until the world is safe. So here, I'd like to share with you all our experience, and I hope everybody get well and healthy, and prepare for a next wave of the infection, maybe in this fall. Okay, thank you.
I think Taiwan's experience has been very illustrative. You have learned well from the SARS outbreak. You have put in a sound platform on which to build on, and there has been transparency and public information so that everybody buys into your effort to control the COVID outbreak.
Yes.
That is the main lesson that we have learned, and you have used smart technologies as well to help you in that effort. So I'm sure there will be more questions as we take from the audience later. So thank you, Wang, for a very good presentation from Taiwan.
Okay.
So thank you again to everyone for inviting us to speak during the session. It's always great to bring international organizations together to share our experiences, and especially to share our experiences during this very difficult and unprecedented time as we are all reacting to the difficulties of COVID. What Lena and I would like to do today is to provide you an overview of how ACHS has reacted to the impact of COVID on our business in Australia and internationally, and what innovations we've actually come up with during this time when we've taken a bit of a pause from our on-site activities and had some time to reflect. So we want to share with you a bit more of a positive note about how we have been addressing the COVID crisis. And thank you to everyone at ASQua for your time today and for that very generous introduction. So what we'll do is I'll start off the beginning of the presentation, and then I'll hand to Lena towards the end to provide some even more information about our domestic business as well. What we'll do is provide an overview first of Australia's journey through COVID, a very short overview, and then highlight impacts on our domestic and international accreditation business, and finally showcase innovations that we have developed during this time. And hopefully this information sharing can also assist all of the other accreditation bodies throughout the Asia Pacific region. Before we progress, I just want to provide a few bits of information about ACHS. We're the Australian Council on Healthcare Standards. We're the largest and oldest accrediting agency within Australia. We are completely independent from government, private, not-for-profit organization. And interestingly, in Australia, we are one of 8 organizations that are approved by the government to accredit all healthcare institutions to our national standards. So there is competition built into the market, which is an interesting note when we talk about the impacts of COVID on our domestic market a bit later. We were founded in 1974, so over 40 years old now in terms of our experience in accreditation and healthcare quality improvement. And we ourselves are governed by a board and also a council from across Australia and New Zealand of the leading public, private, and consumer organizations to ensure that we're staying on top of the best trends in healthcare and bringing that to our international community. Our ACHS International subsidiary was founded in 2005 and now operates in 15 to 17 countries with 100 members and 300 assessors located both in Australia and internationally, which we'll talk about later about how we've had to manage that during the COVID outbreak. Now, we understand COVID has hit many different countries at many different times, but we wanted to highlight what happened in Australia in terms of our restrictions and when they hit and what the impacts have been on our business. In the last about 2 weeks of March is really when we saw the peak in the amount of COVID cases across the country. Before that time, we have been responding in regard to just closing down travel from South Korea, Iran, Italy, very much like all other countries. However, when the peak occurred around March 23rd, our government took very swift and restricted action to close all travel, not only within Australia, but also into and outside of Australia as well. So you can imagine for an accreditation organization that relies on on-site assessments to gather information about quality improvement and adherence to standards, this certainly threw a very large obstacle in our way in terms of how we continue our business, but also importantly, how we continue to support our members in terms of quality improvement support. As you can see by the graph, we have been doing quite well in Australia in terms of the decrease in COVID cases, which is great, and we are starting to loosen up restrictions. However, we'll talk about a bit later, this hasn't yet flowed to our accreditation business and our ability to, again, conduct on-site assessments. Something that we monitor quite frequently in Australia, and we do this at ACHS as well, is something called the COVID growth factor. And this is monitored again throughout the world, but important for us to get an understanding of how quickly COVID is growing throughout our country. As you can see here, the peak turned red or was at its highest towards the end of March, beginning of April, when the amount of COVID cases was growing faster than the amount of recovery. Fortunately, now we're back in the green and below 1 and enjoying loosening restrictions as the actions taken to combat the virus across the country have been quite effective. Our federal government has released a 3-step framework towards a COVID-safe Australia. I won't go through all of these. It can be found online if anyone is interested about how Australia is responding from a federal national level. But basically, the government has given the states the opportunity to follow this framework to reach somewhat normalcy by the end of July, August time, and talking about how different industries across the country can start reopening and getting back to normal. However, for us, we probably will continue to have travel restrictions throughout Australia till the end of 2020 is what the current predictions are. At the moment, we need exemptions from the Home Affairs government to leave Australia. And those are only for very specific reasons that can be approved. And there's also borders that are closed throughout the country. So it's very difficult at the moment for Lena in New South Wales and me in Victoria and Melbourne to travel to any other parts of the country because borders of South Australia, Western Australia, Queensland, for example, are all closed to non-residents of those states. Interestingly, though, there is a thought of a trans-Tasman bubble opening up with Tasmania, hopefully starting from July 1st, where we can travel to our easterly neighbors in New Zealand. However, even though we have loosening restrictions on our travel, this still has, again, a large implication about how we conduct accreditation, both in the domestic market and internationally. At this point, I'll pass to Lena to provide a bit more information on the impacts to our Australian business, and then I'll provide some more information on the impacts to us across the globe. Lena, over to you.
Thank you, Michael, and thank you, Professor Dato, Dr. Ravi. In Australia, ACHS accredits both the government standards and also to our own ACHS standards, which is equipped. Basically, the government's standards are the National Safety and Quality Health Service Standards, which aims to provide a nationally consistent statement of level of care consumers can expect from health service organizations. And whereas for us, the equipped focus for the ACHS standards is ongoing continuous quality improvement. So on the 25th of March this year, the Australian government suspended all on-site accreditation assessments throughout Australia, and correspondingly ACHS also suspended our on-site assessments. However, in relation to both for the government standards and the ACHS standards, ACHS has been able to conduct virtual assessments still, using a range of technological tools together with some of our members. So I think we're going to cover some of that later, But over to you, Michael, about how EQUIP actually is also being assessed from the accreditation viewpoint internationally.
Great, thanks, Lena. So from the international perspective, given all that we have just discussed about the impacts of COVID, while we are not progressing on-site assessments at the moment in Australia, we are working through a resumption plan across the 15 countries in which we work in APAC and the Middle East to determine the restrictions in each one of those countries about how they're reopening travel, reopening on-site activities, and working with our network of on-site assessors both throughout the Middle East and in the Hong Kong region to ensure that we can utilize that great network of assessors on-site and link them up to assessors that we have back in Australia. So while it's a slow process at the moment, we are going country by country to really understand how we are able to get back to some sense of normalcy through the accreditation process. What we really wanted to focus on during this presentation, though, is during this time that we are paused our on-site assessments, we actually have really used the time to reflect and look internally about how we can improve both our services to each other as an organization, but most importantly to our members as well. And through this time, there have been considerable amount of innovations that we wanted to share with you because it may be something that we all need to learn from each other about how we navigate this time in the future. The first thing that we've been doing is spending considerable amount of time revising our standards, and we've brought this forward to ensure that we use this pause during COVID to really dive deeply into think about how healthcare has really rapidly changed in response to a global pandemic. Everything, the impact for medication management, infection control, dealing with the public, dealing with patients in hospital, these have all been taken into account within our standards and really looked at from a different perspective in terms of how we be innovative and respond to the crisis and release a new set of standards that is flexible and adaptable to the international community. We've also invested heavily in technology in terms of developing a member portal for our customers, as well as a free resource about COVID. We call it our COVID resource page, which is available to anyone. And we encourage you to visit our website for those webinars and clinical guidelines from Australia about how we can all assist each other to navigate this time in the future. In addition, as Lena was mentioning, we have also pioneered hybrid assessments. So this is taking a mixture of on-site assessments plus electronic desktop reviews plus virtual assessments in our international community to mix both our on-site local assessors that can still travel to our member hospitals in certain countries, linking them back to Australia with our very experienced lead assessors, and also doing a very comprehensive desktop review. So really trying to think innovatively on our feet very quickly about how we can maintain connection and support to members, but at the same time keep our assessors safe and allow our member hospitals to focus on the response in their staff and communities to COVID. I also want to pass on to Lena to share about what we've been doing in terms of assessments internally in Australia as well, and also how we've been keeping connection with our assessor division.
Thank you. As Michael explained, keeping our assessors safe has been really very much a focus for us as well. And in trying to determine with the government when Australia is ready for on-site assessments, it will be very dependent on when the borders are lifted in terms of the COVID bans on travel within different states at the moment. So how we're focused in terms of ensuring that our assessors remain trained and ready for assessments as soon as the bans are lifted. We have trained them in terms of a hybrid model, both in relation to virtual assessments and still maintaining the on-site competencies. How we've been doing that is with the ongoing training of our assessors. The assessor forums are conducted as webinars with guest presenters, similar to what we're doing here in recording, and having some specialists go on in terms of whether it's for infection control or medication management issues. We also have weekly updates on the assessor portals so that all our assessors, whether they're international based or Australia based, are kept informed about what ACHS is doing, and gives them an opportunity also to respond about their concerns. Aside from that, we also have fortnightly webinars where it's a chat session for all our assessors to communicate via Zoom with us, and also for them to ask questions, and where we cover as well current topics and updates and train them on using the various virtual media and hybrid models we are planning for. Over to you,
Great,
Mike.
thanks, Lena. In addition, we also connect to all of our members to ensure that we're maintaining a sense of partnership and community during this time, and using this time to continuously improve ourselves as an accreditation provider by getting feedback and collaboration from our member hospitals. So this has been certainly a very useful experience for us and given us time to reflect and adjust our operations accordingly to better serve our customers. On that note, we want to thank everyone for listening to the presentation and sharing a short glimpse of what we've done in Australia and the impacts of COVID. We look forward to sharing further experience with you in the question and answer session, and I'm happy for you to reach out to us at our email address for further support as well. So thanks again.
Thank you, everyone.
Thank you, Dr. Lena and Mr. Michael. I think that has been a very illuminating presentation for us on how you have progressed with accreditation. I see that you have a very strong IT-based platform, which you have used to the maximum for further training. I'm sure there will be a lot of questions from the audience later.
Thank you very much, Professor Ravi, giving me this opportunity to speak on this very specific and special webinar being hosted by ASQua. It's my proud privilege to be here, ladies and gentlemen, and good morning, good afternoon, and good evening, wherever you are, depending on the time zone you are in. So it's a great honor for me to present this webinar on role of standards in pandemic. As Professor Dato Ravi just mentioned, the standards played a very critical role. And in my opinion and my experience of last several years, I have seen that using standards makes life easy. However, there are different opinions whether these standards can be sustainable in a time of crisis or during epidemics or pandemics. So standards, we talk about a lot, but what standards mean, and just briefly took you through the slides in terms of types of standards. There are 4 types of standards as defined by European Committee for Standardization, CEN. One is fundamental standards, which concern different terminology, conventions, signs, and symbols used in different sectors, including healthcare. There are test methods and analysis standards, which measures characteristics such as temperature, chemical composition, biological compositions, and biological properties, which are used by hospitals, the laboratories, and diagnostic centers specifically. And there are specification standards, and these specification standards particularly define the characteristics of a product, or a product standard they called, or a service, the service activity standards, and the performance thresholds such as fitness for use, interface with interoperability, health and safety, environmental protection, etc., etc. So these standards basically gives a framework of a lot of functioning in an institute. And then 4th one is organization standards, which describe the functions and relationship of a company or organization, as well as elements such as quality management and assurance, maintenance, value analysis, logistics, project management, system management, production management, and so on. So these 4 types of standards widely cover the entire functioning of a hospital per se in healthcare. Now, I'm taking the 2 only, the last 2 related to specification standards and as well as the specific service standards. So when we talk about a specification standard in healthcare facility, we talk about a lot of public PPEs. There has been a big issue in ascertaining the quality of PPE. And it has been observed that a lot of manufacturers who have been producing PPEs, like the gloves or shields or goggles or whatever overall, they have been certified by certification agencies. But it was very difficult for the users, the buyers like hospitals, to ascertain whether they are of good quality or not, because there is no authenticity on the certificate. It not necessarily mean they are illegal certificates, but authenticity is not guaranteed. So it is unauthentic. And sometimes there are fake certificates. Recently, 2 weeks ago, we came across 2 certificates issued by a certification agency, produced by a manufacturer. Actually, they were not at all issued by the certification agency. So those certificates are the fake certificates. But other certificates which are not fake, but they are not authentic. What authentic and unauthentic PPE certificates mean? There is an international system of recognition of different systems on quality and safety. One is International Accreditation Forum, IAF, at the international level, which actually provides guidelines for accreditation bodies who accredit the certification bodies. And these certification bodies certifies different products and different functioning of different organizations. So if any certification agency is part of this international mutual recognition arrangement we call MRA, it means that certificate is authentic, because you can trace the authenticity of that certificate through certificate, then manufacturer, and then certification agency, and then accreditation agency, and then international accreditation forum. So this way you can link up the quality and the safety of specific PPE. And we have been talking a lot here in India, and we are doing things which can improve the quality and acceptance by the manufacturers as well as the users. And it has also been seen the limited oversight of regulatory and testing standards. In India, we have Bureau of Indian Standards, we have now Ministry of Textiles, which is regulating a sort of trying to control these PPEs, and we have Drug Controller General of India. And when products come with CE marking, there's a CE marking from European. So I think there are other standards brought out by Europe in order to control this quality of PPEs. So this has been a great challenge, and I'm not sure about what is happening in other part of the world, but in India we have been facing this challenge, and we have been seeing that complaints by healthcare workers when they are donning the complete coverall and they are sweating inside, and as per specification that suit which they are donning actually breathable. It should be impermeable for blood and body products, but body fluids, but it should be breathable. But it is being complained by users that they are sweating a lot and they are highly uncomfortable into that. So I think these are concerns some healthcare staff is facing at the moment. Now coming to the organization standards in healthcare facility, all we know that there are regulatory standards which are minimum to be followed and implemented because they are required for any licensing to operate the healthcare facility. Then second level comes for the service of quality management standards, which are purely voluntary and healthcare facilities adopt to choose for improvement of their services. For example, ISO 9001, a general quality management system, or 14000, which is related to environmental management system, and there are a couple of other quality management systems. The third one comes the accreditation standards, and as I think colleagues from ASQua, most of the members are coming from accreditation bodies, or they are associated or affiliated with accreditation bodies in one way or other way. So they know about accreditation standards. So these accreditation standards actually bring more process-oriented approach into the hospital functioning, which actually ultimate to provide good care. So I think I'll just touch upon these standards. Now, accreditation standards in healthcare basically used by the diagnostic laboratory and imaging centers. There are international standards called ISO 15189, but a couple of accreditation bodies develop their own accreditation standards for diagnostics. So those can also be used, but internationally for pathological or called medical laboratories, ISO 15189 is the international standard used world over. And in hospitals and other facilities, in this, basically each accreditation body develop their own set of accreditation standards, and these standards are then further, again, it's a voluntary process. They can go to International Society for Quality in Healthcare, ASQua, for getting recognition of their standards, and accreditation organization as an organization itself, which gives them international acceptability and the benefits of going to the global market. So why the basic questions comes, why we need to implement or use standards? We talk about the standards, but what is there in why we use them? So maybe I just a hypothesis, maybe just to achieve quality for better patient care, better safety, maybe staff safety, community safety, and so on. So I just link this statement with my following slides. So standards world over have been, used as a framework to achieve desirable goals, and then healthcare is not an exception to that. Standards for accreditation have always laid down a set of requirements which are usually higher than basic, and which are requirements for licensing as a regulatory function. So they make the healthcare system more resilient. It's become more sustainable. Standards provide an opportunity to healthcare providers to look at their systems, the policies, procedures, different processes, different training aspects of the staff, infrastructure in terms of premises, building, equipment, for better preparedness to respond to any emergency, and in terms of ultimately leading to a standardized approach for structures, processes, and outcome. So the accreditation standards basically drive the agenda, starting from structures and then use of different processes to give out good outcomes. So if you look at the roles of standards for patients, and I would see is like when you implement standards, they provide patient-centric care. They are really high quality of care, and no doubt that the patient safety is increased. Patient gets services by competent staff because there are criteria, there are standards revolving about credentialing and privileging of the staff working in the hospital. And the rights of the patients are respected and protected. And particularly in the crisis time when there is a pandemic and people are rushing and nobody is perhaps bothering what's going on around and just trying to provide a care. But it's essential as well that we really need to take care of their rights as well in terms of providing better accountability and transparency in treatment cost and over and above the ethical considerations. While a patient receives care during crisis, whether the ethical considerations are being given or it's just like anything is being done. And the role of a standard for staff is again very critical, and it gives an opportunity for continuous learning, good working environment. And this is very relevant to the current situation of COVID-19, seeing if this virus is highly contagious, and if they are not, provided a good working environment, which is required, then they might adversely affect and definitely increase the staff safety. And staff training is the part of the standards, and in fact, how to use these PPEs properly. Using PPE is not difficult, but using it properly is the most important thing. So slightest deviation from proper utilization of these PPE might result into a dangerous situation for the person who is going to use it. So I think training on different aspects related to the occupational hazards, related to the surroundings, the environment, I think come very handy while we have the standard in place. And the role of standards for organization is to use. They have the disasters or emergency response plan in place to manage emergencies, including pandemic, like many disease outbreaks, include pandemics, and then they have well-structured infection prevention and control program in place. And the standards health facility in better equipping with PPEs, and also which are available at all times. It's not just when there is a crisis coming up and then you start looking for. No, they know what they need, and they have what is required at that particular point of time. And in case they need more, they have access to, they know the mechanism how they can access to the more quantity. And staff is regularly trained and educated on appropriate use. And so this is very important. When we hear that there are a lot of training being provided to staff on the precautions to be taken and use of PPEs, and if the hospital is already implemented the standards, these things need not to be worried about because they are a part of their inherent system. So standards contribute to hospital readiness and ability to adopt existing system to respond better to the effect of any pandemic. So it's just like another day for them. It's just like a little more work for them, but it's not very much what they have been doing or they were preparing for it. And the healthcare facility identifies, evaluates, and manage immediate and potential risks to patients, staff, and visitors. So this is again a very pertinent question which we raise: how healthcare facility is prepared for managing, any pandemic. So this is the answer for those things, because These are part of the standards which hospital implement, so they need not to worry about it. And there is effective collaboration and cooperation amongst everyone around the ecosystem, and there is public awareness, and there is a trust which helps in early and easy response to any pandemic. So it's always sad in hospitals when we start implementing the standard that you always follow universal precautions. You know, it's not just when you look at somebody is infected that you start looking for following precautions. No, you consider every patient is a potential infectious patient, and then accordingly you must have all those precautions in place beforehand. So sometimes the contention, many people raise question that it is very difficult, you know, to put documentation in place and following standards when there is an emergency. And I always argue with them in a positive frame of mind that you may be right that you need to put a lot of documentation, but I think that is very critical and essential. It's not only gives you an idea of what you have been doing with patient, but what the patient is being referred to another one or another consultant or another doctor. He also knows what has been done with this patient. So it's avoid a lot of medication errors. And everybody knows that there are thousands of medication errors occurring around the world. So in absence of any proper documentation and clinical notes in the patient file, it leads to medication errors. It can implement a problem in correct treatment plan if you are not identified and noted it. And the documentation also gives you an evidence of care, and it minimizes the litigations, you know. So its documentation in clinical care is very essential for the benefit of everyone, definitely for patient, but the provider as well. And so following the standard and in a time of crisis is also equally important as providing care to the patient. And overall, when you have implemented the standards in your institutions, you applied good processes, good practices, and you enjoy the implementation at every time. It's not just one-time activity. All the time in the functioning of hospital and healthcare facilities, you're bound to get better outcomes. So the role of standards are very critical to get the better outcomes. And particularly in the times of crisis, the pandemic is all the more critical. So with this, I would like to end this presentation. I would like to thank you, ASQua, for giving me this important opportunity to talk to the people around and share my views on the role of standards during pandemic. Thank you very much.
Thank you, Dr. Rana, for a very lucid presentation. I think you have alluded to the fact that standards are the very foundation of healthcare, so that it ensures patient safety and good quality of care to every patient.
Thank you, Prof. Rafi, our Executive Chairman. Dear colleagues from ASQua, I'm going to present on behalf of Dr. Sutoto, my boss, about Indonesian COVID way, a long way to go. This is the first case in 2nd of March. This is our health minister. And this is the case. There's in Wuhan, it started at December, and until that time, end of February, no cases in Indonesia. So WHO adopted whether there is no cases or it's underreported. And then there's an dance teacher in Jakarta, and she danced with a Japanese lady stationed in Malaysia on the 14th of February. On the 16th, she got cough and go to the hospital, but they let them home. She let her home. The Japanese lady goes back to Malaysia and got flu on the 17th. This is 16th. But 10 days, it's not getting better. She go back to the hospital and get hospitalized, this Indonesian teacher. And then the Japanese lady in Malaysia, she got hospitalized on 22nd. and 26 is declared positive COVID. So they make a phone call to Jakarta, to the hospital, and on the 2nd of March, this lady was declared as the first case of positive, and her mother became the second. The president himself stated that time we got to fight against Corona, but now he changed into we got to live with Corona. This is our spokesman, and you see here the trends is still going up in Indonesia. This is the new case. This is the death in Indonesia. This is the world still going up. In Indonesia, all province, 34 province have positive cases. This is in the world from WHO. This is the whole world. It's now already 6 million. And you see here, the Southeast Asian, the violet one, is rather low. Indonesia is Indonesian map is stated by WHO, all positive in all places. This is the history. Maybe everybody knows already. The 31st of December in Wuhan, and then we start at 2nd of March, and then we spread this WHO standards about what's Corona to the whole country. That time we said we fight Corona, but now we cannot fight with Corona. And this is some special dates about COVID-19. So after the 2nd of March 2020, the president announced that the first and the second cases of COVID are there. On the 13th, 11 days after that, there was a special COVID task force to operate a general Doni Murdono. And 10 days after that, they make a whole tower, athlete tower. We see the picture after that. Become a COVID hospital with 3,000 beds. It's not used because it's after SEA Games. And then on the last day of March, the government state large-scale social restrictions. This is a little lower than isolation and through quarantine. So it depends on the province whether they will put it or not. The 2nd of April, travel ban everywhere. Rapid test in the 6th of April, around 600 positive in one test. Yeah, and then now we are already talking about new normal. This is what we say large-scale social restriction. Schools and work must close. Shops must close except for daily use, and pharmacies. Most church must close. Funeral only maximum 20%, and no activities outside at all. But we don't have a fine. We don't penalize if somebody get outside. This is our athlete hotel that become the whole building become a hospital, and it's also the home for the doctors and the nurses. They changed hotels. Many hotels are collapsed because nobody goes to the hospital to the hotels, so they changed into hospitals. There's also a mayor place in Banyuwangi. He go out, stay in the office, and let his house become a hospital. This is Plaza, Lipo Plaza becomes a hospital also. This is ex-Vietnam refugees in Galang Islands. Maybe 30 years ago, it became a hospital for isolation for people coming from abroad. Many hotels change not to hospitals, but they give free lodging for the medical staff. because many medical staff cannot go home because they are afraid to spread to their loved ones. See, Hotel Jakarta Turisindo, 7 hotels become, so I think it's about 30 hotels become free lodging for medical staff. And this is funeral because there are a lot of rejection to COVID funeral. So all the province make a special place, a special COVID funeral. See, only for COVID funerals, they cannot be buried the Muslim way, must put in a coffin, just like the WHO standards. Work from home, already 2 months, and we. What about the accreditation system? So we fill in the time of the surveyors and the hospitals, usually after 1 o'clock, and then we make a lot of webinars, maybe 1 or 2 a day, or maybe 5 or 6 a week. WHO talk several times, World Bank. From GCT, Professor Pa-Chun Wang, he's talking just now, and then Michael Giuliano also talking today, and Professor Kadar Marikar, and we are going to go to Dr. Anuwat and Prof. Yuichi, maybe later, and a lot of more. What about accreditation itself? We are pushing because we have stated that in 2020 there will be no on-site accreditation from CARS, but we changed it into online accreditation. So we have tried several times. A little difficult in the first times, but we have to do it until change of the year. And then a lot of fun gathering from home, fun gathering. This is all Indonesian artists. They sing together through Zoom, and then they got a lot of money. The president also make a Zoom presentation with Bimbo, and this is Didi Kempot is one of famous artists in Indonesia. He make a concert from his home, and the next day he died. Yeah, he get 9 million rupiah at that night, 9 billion rupiah to give to the COVID patients. And then there's a change of industry. Most of the industry go to medical equipment, make hazmats, make hazmats, make maskers, everything. Some people still doesn't care about social distancing. You can see here a lot of people gathered together without any mask. A lot of medical personnel died, maybe more than 50. This is all nurses, very, very sad. Now in some places there are already no red zone, so they start to loosen their tightness of the isolation. This is from yesterday. So world corona is 6.3 million. That's 300, and Indonesia is still growing up. A lot of higher than Australia and Malaysia. About COVID funding, Indonesia declared to spend 405 billion rupiah, trillion rupiah, yeah, and nearly all projects stops because nearly all projects goes to COVID. So we spend about 2.5% of the GNP. This is the last lines. This is new normal in Indonesia. We have three rules. If you want, if the province wants to do partial open the lockdown, the reproduction rate must be below 1. Now it's a little bit still near to 1. Health facility readiness and enough PCR and swab tests. From WHO, it's 6. 6. Yeah, so we take the first 3 only. And then this is the last slide. The police goes everywhere with this COVID head to scare the people. Just a funny thing. Thank you very much.
Thank you, Dr. Hanny, for sharing Indonesia's experience with COVID. It has indeed been life-changing, I think, for all of you all. And I'm sure there will be many questions towards the end of this webinar. Thank you very much.
So thank you so much to ASQua. Thank you so much to Dr. Ravindran sir for giving this opportunity. And COVID-19 is still an evolving scenario. And I'm here to very, very briefly give you a pictorial journey of the India experience, what we were, what we are, and what we are going to be. Proud to be associated with ASQua. And actually COVID-19 has had an unsettling effect on the world. And lessons, we cannot say the lessons are learned, because in hindsight, the vision is 2020 and we are still amiss. We have not peaked out also, and every country is facing there are more than 200 countries. There are, I mean, lakhs of deaths. I mean, this is a very, very unsettling scenario. In that, I'll just briefly tell you, I would like to reintroduce to all our members what exactly is NABH in very, very few slides, what we are doing, what we were doing, and what we hope to do. Quality Council of India was set up in 1997. It is a direct collaboration, a public-people partnership sort of thing with Government of India, with ASSOCHAM, CII, and FICCI. And it's an autonomous body organization under Department of Promotion of Industry and Internal Trade, DPIIT, along with Ministry of Commerce and Industry, Government of India. Our chairman is appointed by the Honorable Prime Minister of India, and currently Mr. Adil Zainul Bhai, he's a leader in his own right, is the chairman, and Dr. R.P. Singh is the Secretary General. We are the pivotal body to provide accreditation framework, the quality framework, to create an ecosystem of quality in all domains. There are 4 accreditation boards, and there is one quality promotion board called NBQP. Amongst the accreditation board, there is one NABCB, the NABL, which is responsible for the labs. NABH, we are proud to represent currently, is National Accreditation Board for Hospitals and Healthcare Providers, and Education and Training, we have NEBIT. Then there are a whole lot of special project groups and about 750 people working in various projects, from Swachh Bharat to coal to yoga. So it's a multifaceted dimension. We are proud again to be member of all international bodies. We are on board of ASQua. We are a part of ISQua. And we are practically involved with a whole lot of government schemes, commerce industry, health and family welfare, road transport, petroleum. So as you can see, I mean, we are part of the official face of quality in India. These are certain other projects which we have been involved in, ranging from food and agriculture to industries, various facets, from zero defect, from Ayush Mark, for production of traditional medicines, to a whole lot of things. We are proud to say that NABL during the COVID time, amongst its range of industries, has been at the forefront of accreditation, certification of various labs, capacity building related to reverse transcriptors, PCR, assays, from approval of PPE. So it has a huge range of labs, about 5,400 labs, amongst which 1,100 are the medical labs. This is NABH. We are currently running 16 programs. As most of you would be aware, there are a whole lot of accreditation program, then certification programs. These are our unique aspects which we have been handling, entry-level standards. Because of our mission to take quality to the roots, we are taking to the smallest clinic, and we have a very robust empanelment mechanism. And currently there are 8,500 plus healthcare bodies, and we had hoped to touch about 20,000 by the year end, 20,000 by 2020. That was the motto we had begun with, but let's see how best we can stay on to our path. The year 2020 started with a bang, actually. Very, very auspicious note. We launched a whole lot of schemes. We launched a standard, actually. This was the 5th standard, which has already received in April the stamp of IEEA. So this is a wonderful thing. Our 5th standard is a very robust standard. It gives lots of clarity and coherence to our assessment mechanism about core, commitment, excellence. I mean, this is a wonderful, and these standards are available free of charge on our website, so anybody can download it. Now our certificates have university level, industry standard anti-counterfeit mechanism. There are a whole lot of measures. We gave clarity to the certification. So what exactly COVID did to us, to the national thing? It brought back from 1809 Charles Darwin's theory that either you adapt or you perish. So in our bid to adapt, we tried to adapt to the new normals, social distancing, masks, hand hygiene, everything. I mean, so this is and we adapted to work from home. So we had to now work from home with all its constraints. We have a large panel of lady staff, and they're very proud. I'll place it on record that each one of them, despite all their constraints, worked as a unison team. All boundaries of ours were gone, actually, and they worked together to perform as a team. And we held about 1,000 plus meetings and productive meetings, more productive meetings across board. We reached out to ASQua, we reached out to all our stakeholders, and these meetings were very, very productive to reduce pendency, to draft new policies, and we came up flying in that respect. The work from home has been a success for NABH. We brought new standards. We initiated new standards, and we are proud to say that NABH is the first accreditation body in the world to launch digital health technology standards, of which telemedicine is a small part. But we are looking at interoperability. We are looking at visualization, health analytics, M-wellness, so M-health, wearables, so everything. So this is a very comprehensive standard we wish to place in public domain very soon. And we are in touch with ASQua for this. And this standard can be a game changer in giving clarity of thought to telemedicine and digital health platform. And we have the support of Niti Aayog, Ministry of Health and Family Welfare, WHO. We have nominees from CDAC, Bureau of Indian Standard, and everybody who matters. So this is going to be a very comprehensive digital health technology. We started out e-learning platform. So this was a good opportunity. Working from home was a good opportunity to reach out to people. And just like people newfound toy, we also jumped onto the webinar wagon. So webinar, and we did currently, we have done about 30 and continuing, but these have been very well received. About 3,000 people maximally have logged on to their, our webinars. They have benefited from these, and they've ranged from Ayush, they've ranged from discussing the relevance of quality in time of crisis to basic life support training, which is current one is scheduled on Saturday coming. Please, all of you wish to log in and avail of this benefit on 6th, you can log on to our site and join this training free of charge. Then mental health, emotional health. So all these factors we discussed in the webinars, and they're continuing. Ventilator capacity building. We partnered with CII for a series of 12 webinars, and then SOCHM, then a whole lot of things. We worked very closely because across world countries found their newfound warriors. So nurses, our front-end staff, our doctors, our resident doctors, our paramedical staff. So everybody, so nation, we NABH joins the nation in saluting all our warriors, and not only lip service. We have reached out to everybody who's working with healthcare. We have shared data across platforms. We have worked on making PPE available. We have worked on taking quality guidelines to people, so our website, through our backend mechanisms, we have tried to reach out to every nook and corner of the country to capacity building in their fight against COVID. So this is what. Now coming to future, well, this is still evolving. There is lots of uncertainty ahead, I searched articles and the press is full of hundreds of articles about what the future looks like post-COVID. I mean, future predictions. So everybody is onto that, how technology will transform healthcare, how COVID-19 will help us think differently, looking beyond tomorrow. I mean, they have such wonderful resources, which is not possible to discuss, but I can only say that this is a rough graph, the rough chart showing what it can be. But whether the future of medicine is going to be digital, whether it's going to be tailor-made, whether technology, artificial intelligence, home care. So these are just thoughts which are there, but the reality is it's all very gray. Not one shade of gray, not 50 shades of gray, but a million shades of gray. So as things stand today, nobody knows where we are heading. Nobody knows where we are heading, but as father of the nation, our Mahatma Gandhi ji said, the future depends on what we do in the present. And that is what we believe in at NABH. And we also realize that we cannot control anything. Everything is beyond. So what this COVID has taught us is that only things we can control is our positive attitude and our own scenarios, our own reality. We cannot control anything. And all we have is now. And we believe that we are the face of the industry. For all our partners, we assure you of service, quality, efficiency, reliability. I mean, you are our customers, actually, if we can say that. And we also believe that if our foundation is strong, then nothing can sway us. Our foundation has to be built on objectivity, transparency, trackability, a very, very strong core of propriety, probity, and integrity. And this is what we truly believe in. And NABH will come up, and this is a WhatsApp forward which I received 2 days back, that you have to be like a tree, stay grounded. I mean, be very, very realistic to your roots, connect with your roots, and our partners, our assessors are our roots. Turn over a new leaf. We want to connect to them. We want to take teaching, training to all of you, and we have to be flexible, otherwise if we bend, if we do not bend rather, I mean, if we are not flexible, we'll break. We have to enjoy our unique natural beauty, which NABH has core values which we want to strengthen and keep growing. So we have to be green, we have to be going back to nature, paperless initiatives are always wonderful. Be flexible, connect with people. And ultimately, what are all we into is this wonderful words of wisdom from our Gandhiji, which says that whenever you have a confusion, think of the last man in the line. So our policies, are they touching those last people who are affected by any change? Our policies should be geared for that. And this is a true this thing. And if all of you Hindi movie fans out there, as I am, don't be bogged down by negativity, because there's so much positivity and picture abhi baki hai mere dost. So that is one takeaway. And the other is that NABH is your face, is your friend, and under any adversity, we have strong foundations, and we promise to come out of it with flying colors, and we are there to cooperate with all our industry partners. So, namaskar and Jai Hind.
Thank you, Dr. Atul. Wonderful. I think you have laid a strong foundation, especially with your digital health standards, and making it sure that that is in place at this time of this pandemic, when a lot of it very much depends on IT-based platforms. Correct. So we have heard now from National Accreditation Board of India, and I'm sure there will be a lot of questions later during the webinar. and we will look forward to your answers. Thank you very much, Dr. Atul. I hope you enjoyed the webinar so far, and all panelists, welcome again.
Yeah.
Yes.
Hello. How are
Hi.
you? Good afternoon.
Hi. Okay. All right. I will ask Dr. Pa-Chun
Yes,
the first question.
Okay.
All right.
Yeah.
Your opening statement was professionals must be in charge.
Yes.
All right. That has stimulated some discussion.
Okay, good.
Do the politicians allow it in a democracy? Is it possible? But what's your response to that?
Okay. So can you hear me?
Yes,
you hear
I
me?
can.
Okay. So this is also the lesson we learned from SARS. Okay. So at that time, local government, central government, they don't cooperate very well. So it turned out we decided to have a national commanding center, so that can coordinate all the resources together. Okay. So in Taiwan, we further divide the status into the level 1, level 2, level 3, which level 1 is the highest level. Okay. So at this stage, the commander of the commanding center has the power to order even the national defense, the Ministry of Interior, or the Education Department. So the level is very high, and not to say the local government. So all the government, local government, and all the ministry, they need to listen to the commanding center this time. Okay. But you know, during the previous infection, like H1N1, H7, H7N9, and the MERS, you know, the infection was not so severe. So that was only a level 2 or level 3. So the commanding center has very limited power. But this time, you know, since it's a pandemic, so we quickly raised up the level to level 1. So the commander has a huge power to make the politician listen to them. So I think the coordination of the national coordination is very important, right?
Okay.
So you can see the chaos in United States, you know, because there seems some conflict between the local and the federal, so that caused a big problem, right? Yes.
Right. Okay. Thank you for that response. The other is, you know, in these times of the pandemic, how do hospitals, especially the accredited hospitals, keep your staff motivated? Anyone can answer from the panel. How do you keep your staff motivated? Maybe India, you are in the middle of a pandemic. Dr. Atul, can you hear me?
Yes, sir. I think it's a very, very important point to keep everybody motivated. That's a very important point, I believe, because in the pandemic, the front warriors, I think each of us has a role to play. The media has a role to play. The politicians have a role to play. Our colleagues have a role to play. Because as we start learning, because we are still evolving and we are still learning, we wish to know that from our colleagues also how they are managing this. Because now there's a sense of when the pandemic does not behave as expected, when the graph does not taper off as expected and the rates keep spiraling, then it's very easy to get frustrated because that mental challenges are there. Because and we must believe that all hospital staff are doing their best in this battle worldwide. So the politicians now are playing a role. They are going on ground now as we are learning what the politicians do. And as far as the organizations like NABH are doing, so they are going beyond their scope, let's say, of accreditation or certification, and they are doing these webinars. So to every aspect, I mean, doing a webinar and reaching out to people, telling them about the disease, giving them authentic information. These are certain ways, because once you give authentic information, the staff feels empowered. The staff feels empowered, then you have to dispel the myths also. I mean, there are so many myths and so many fake news which are circulating. So I think it is the responsibility of not only government, not only our colleagues, but each one of us to provide right kind of information, right kind of training, because when we partner with a business organization like CII, we learned that everybody wanted to help. Then we partnered with FICCI also with a series of about 12 programs which did ventilator capacity building. So our colleagues in other specialty from critical care, they were not aware about ventilators. I mean, they must have learned it in MBBS, but then going forward with so many years, I mean, everybody forgets what a ventilator controls looks like. So these were very well received. So with capacity building, right kind of training, dispelling myths, right information, and I think standing with them, because every hospital, we know the incoming revenues may not be as before. Our profit lines are going to dip. So understanding their predicament, you know, giving them overdraft, or I mean, not penalizing them for unintentional absences. So, I mean, there are 100 facets to this. If we could discuss this, I mean, but each one of us has to play a role, as our some senior colleagues have just now highlighted. And it is really commendable how each of the panelists today outlined their war against this thing and how they are coping up. There has been so much learning from all of them. Thank you so much.
Thank you.
Yeah, been a wonderful.
Would Indonesia like to respond as well in terms of how do you keep your staff motivated in Indonesia during the pandemic? Would any of you like to respond? Dr. Sutoto or Dr. Hanny?
Prof. Rafi and ASQua colleague. As you know that Indonesia is the fourth most populous country in the world after China, India, and United States. With we have 273 million people, and as we know that COVID-19 cases in the world dominated by United States of America with more than 2 million cases, and Indonesia is at level 31 on July the 16, 2020, we have 40,400 cases been confirmed, with 2,013 recoveries have been recorded thus far.
Right.
And confirmed cases have been reported all throughout the archipelago, and the number of area with local transmission continues to grow. And in this COVID time, Indonesian Commission on Accreditation of Hospitals do work from home since early of March 2020. And all of staff, we met twice a week virtually. And now we have around 13 activities each week around meeting, webinar, classes on virtual communication and virtual accreditation, etc. We started virtual accreditation verification, and we also do focus spatial survey, and we perform also a small accreditation for small and remote area hospital. And we decided that in 2020, we will perform all accreditation survey activity virtually. And maybe we will combine virtual and on-site next year before COVID subside. On this occasion, I want to thank personally to my colleagues, Professor Pa-Chun Wang from Joint Commission Taiwan, also Associate Professor Kadar Marikan from Malaysian Society for Quality in Healthcare, and Michael Giuliano from Australian Council for Healthcare Standard International, for your healthy collaboration to CARS and Indonesia, who have presented the experience of their country in our webinar. And I think also I want to congratulate Asia for organizing such a big transnational webinar. And I think we should not stop here, but move forward to perform wider and bigger events with stronger cooperation through ASQua, and we will move forward together through this pandemic. Thank you.
Thank you, Dr. Sutoto. Now, I want to address all panelists about accreditation. There are a lot of questions on that. In this time of the pandemic, many countries have stopped accreditation on site. But Australia talked of a hybrid model, and other countries have a virtual model. So maybe I start with Dr. Rana. In terms of the standards, what are the changes in the standards that will need to be made to accommodate whether a hybrid or a virtual model?
Thanks, Dato Ravi. Thank you very much for this opportunity. I think in terms of changing the standard, I think there are not changing the standards because standards are always the same. Only the evaluation methodology might be changing. And as of now, before pandemic, everyone was going through the on-site evaluation of accreditation processes. But now after this COVID-19 pandemic, perhaps different methodology will come out, and some have already started. This may be completely online, what you just mentioned, based on the risks involved in the areas affected by COVID-19. It may be a hybrid model where a few surveyors, assessors can be on site based on the availability in the local area, which not require much travel, and also the online evaluation. Might be in some area, it may be completely online. In particularly India, maybe Atul would add to that, that we have a lot of states representing across the country, and we can have resources. We perhaps have the resources in individual states. So we might look at those opportunities if it is possible to use assessors or surveyors from nearby region, not requiring much travel time. So I think depending on the risk involved, related not only the hospital staff, patient, but the assessors, the surveyors who would be visiting, the different accreditation body would come out with their own models. So I think, in my opinion, it's going to be sort of at least three combination until some other technology come out to replace all these three. Maybe the entirely virtual, maybe entirely on-site, and the hybrid model. But I think most of the accreditation body would be going hybrid model, perhaps because the risk involved may not be the same as in one part of the country to the other part of the country. So that's my opinion. I leave it to my other colleagues to further add to that. Thank you very much.
Can I ask Australia then, ACHS, in terms of the hybrid model, what advantages or disadvantages have you found so far?
Sure. Before I address that, Professor Dato, I just want to say in terms of our international and domestic market, they are quite different. So in Australia, the accreditation is governed by the Australian Commission on Safety and Quality, which has indicated that we are no accrediting agency within Australia is allowed to do either on-site or further virtual assessments at the moment, unless they are virtually required for follow-up and rectification of certain areas. Internationally, we do have a little bit more flexibility. And we also have quite a lot of assessors based outside of Australia in Hong Kong and around Asia Pacific, as well as the Middle East, which allows us flexibility to conduct a hybrid assessment. We found that those have worked quite well because we are still having the rigor and comprehensive nature of an on-site assessment with people physically there speaking to staff and patients, but linking in virtually to our lead assessors in Australia for additional queries and additional questioning of the practices occurring on site. And then the assessors are able to take them to those different locations. So hybrid does work quite well. Obviously, as we've all seen, there are hiccups with technology at times, which are expected. But as long as we have processes in place and training of certain assessors to do that, we've come up with also teams to assist on site with all of those logistics as well. So we found it worked quite well. We do prefer the hybrid model, especially for new members that we are accrediting and don't know very well in depth, to ensure that we are maintaining the rigor and integrity of our accreditation program.
Okay. Dr. Lena, do you want to add anything to what Michael has said?
Yeah, just in addition to what Michael has said as well, apart from the mandatory Australian government accreditation that we have in Australia, we also have our own standards, the EQUIP program. And basically in terms of how we have assessed virtually, it's adapting to, we don't force the hospitals to use any of our virtual technology. We actually go with what the hospitals, the healthcare facilities have. And so that has meant quite a lot of training in different sorts of technology for our assessors.
Thank you. Now, another burning question among some of those who attended. Is there a difference in the outcomes of COVID patients or in the care provided to COVID patients between your accredited and non-accredited hospitals in your countries? So maybe I can start with Taiwan, and maybe every country can take a short turn. Right.
So in Taiwan, over 90% of the hospital are accredited by JCT. And this time, we don't have many COVID cases. Right. So all the COVID cases, they need to be quarantined in a specified hospital. So we don't have this kind of issue, because they need to, they have the luxury to be put in the high-level healthcare facility. We don't even activate our surgery hospital. So so right now they've been taking very good care in a well-equipped hospitals. Right.
What about India? Any feedback from either Dr. Atul or Dr. Rana?
Basically, I would 100% concur. I mean, quality is the foundation on which our all major hospitals are built. Though the initial load was handled by public funded institutes, many of which are not accredited, but the stars in the show are our key hospitals, and 100% of which are NABH accredited. So it has definitely made a difference. All our accredited hospitals are very used to SOPs. They are very used to adapting to changing circumstances, used to drills, and they very quickly adapted. I would also just in a line like to submit that NABH has already firmed up its policy on remote assessment and hybrid assessments. Hybrid, we are waiting for the lockdown to open in certain states, but the pilots of remote assessment have already been very successful. We are just scaling it up now. Earlier we were doing 2 in a day, now we are aspiring to do 10 in a day. So that is going on very well with that thing. But quality makes a difference, and NABH has certainly stood up to the test of time. You are muted, sir. You are muted. Professor Dato, you are muted.
Yeah, okay, right. Indonesia, any comments, please, regarding accredited and non-accredited hospitals in terms of outcome?
Yes, maybe from Indonesia. In Indonesia, accreditation is compulsory.
Okay.
So nearly 2,900 hospitals. I think about 15% are not yet accredited because they are small and they are new.
All right.
So and in Indonesia, because we are 17,000 islands, and the economic is not equal in all the places. So in CARS accreditation, we have 6 classes from 1 star until 6 star international. So we have made a study that we are going to report in in Florence, but we failed them. We see that there's a difference between hospitals that get 5 stars against the lower one in performing all their standards. And we got a lot of statements from the hospital that they are very grateful to CARS, because if they are not accredited by CARS, they must be in ruin, because now they are already used to the infection control, etc. Thank you.
Right. Now, just maybe a final round of questions to everyone. In terms of the post-COVID scenario and accreditation, what changes do you expect will happen in the standards or in the process? I think some of the process you have already alluded to, but in terms of the standards, in terms of pre-hospital checks and so on, and pre-surgical checks, do you think such standards will be incorporated into the general hospital standards? What about Rana? Maybe you can start off this comment.
Thanks, Dato. I think, as I always maintain, to ask any of our colleagues here and from different countries, the accreditation standards which are existing, they can very well be applied in any situation, including the COVID-19 situation. Because what we are talking about, basically the infection prevention and control, and that infection prevention and control, either for the staff or for the patient or any visitor, are a very integral part of any accreditation standards which we all are using. Right. The only thing which at the moment has come out is that we really need to follow what we always say, universal precautions or standard precautions at all times, while dealing with patients or dealing with any visitor or even amongst the staff, because we don't know who is a carrier because of asymptomatic nature, who we don't know. So these precautionary measures need to be taken to ensure that we do not transmit the infection amongst the staff, amongst visitors, amongst the patient itself. So in my maybe of course to make more robust system, the standard might be modified a bit to stress upon more on such practices which are actually now at a part of a annual or policies. So those things might happen, but again, I am of the opinion that the standards stand as excellent as they are today in any circumstances. But only thing, we need to change our mindset and practices, because it costs time and money both. Because when you have to ensure yourself to protect, you have to all the PPEs on board and everything. They really cost time to donning off, and then also the money involved. So maybe these practices would take lead at the moment and future. Otherwise, in principle, standard, I think they are quite well at the moment to take care of any epidemic like this. Thank you very much.
Maybe Michael, any comments on this post-COVID scenarios?
Sure, I agree with you that we've discussed the methodologies, and they will certainly change as the world starts to open back up. Our accreditation program has an annual event each year, be it on-site or off-site. So we will probably maintain that rigor, but it will look different certainly for the on-site events, as we've discussed. We're certainly in a lucky situation here at ACHS because we're going through a huge rewrite of our standards from Equip 6 to Equip 7. And COVID happened right smack bang in the middle of that. So we're certainly having a lot of learnings from how our members and the world has reacted to COVID, the lessons learned from good preparation or poor preparation, and trying to incorporate that into the 7th edition of our standards as well. So we're trying to bring everything together to share that with the rest of the world and internally in Australia as well.
Taiwan, any comments on this? You have stopped all accreditation in Taiwan this year.
Yes.
What about next year?
Yeah, we stopped the So we stopped the accreditation for this year, but actually we did provide a consultation service to around 200 hospitals. So it was a kind of a survey for the readiness of the hospital. So in the post-pandemic period, I think we will need to revise our standards based on the new scientific information about the virus. Because even though the principle is the same, you know, but many emerging information tell us that we need to modify our strategy to cope with the new infection, which is COVID-19. And I think the second wave of the infection, you know, seems inevitable. So we need to be more serious about the virtual survey, on-site survey. So we need to develop a methodology. You know, maybe one day we will need to use that. And the third, because previously Taiwan has been very rigid on the expiration cycle of our accreditation. But I think in the future, we probably will need to be more flexible. So for the short notice or even non-notice survey, you know, and many hospitals, they want to be accredited, you know, so they have more time to prepare for the anti-infection. So that's more important work to them than to the accreditation. So we need to provide them a more flexible schedule. Yeah, right now, because some hospitals, they think they want to be accredited this year, you know, they want to pass, you know, and they want to take some rest, and they have a spare time to prepare for next wave of the infection. Yes.
Thank you so much for your comments. I think we are running a bit short of time, so I'm going to ask everyone to just give one lesson that you have learned from this COVID pandemic in the changes that you see in healthcare. I know it's a very difficult question to answer like that, but because of time, I'm going to ask you for one comment. Dr. Atul, I'll start with you. Your mic, please.
Atul, mute. Unmute.
Mute. Okay. Your mic is muted. All right. Okay.
I think if one comment is to be made, then that is be ready for change, because change is the only constant and nothing in this world is permanent, and you have to be ready. Just like our standards are going through 4 or 5, I mean, be ready for change always, and never say never, be positive. I mean, have a very positive mental attitude.
All right. Okay. Dr. Rana, your chance.
Yes, thank you. I have a philosophy, and I think it's very timely. A philosophy is change, adapt, and improve. So like Atul mentioned, change is inevitable. So you have to change according to circumstances, and then you have to adapt, practice those changes, which definitely lead to improvement. So change, adapt, and improve. Thank you.
Dr. Sutoto, any comments, or Dr. Hanny?
Yes. Maybe I will answer.
Yes.
We have 1,000 surveyors, and now we have a new job to train them into virtual communication, and they got examined, and they got competency certificates. Everybody must do the certificates, and also we have to train the hospitals to communicate with virtually. And also we make trainings about video graphics. So the hospital must do part of their accreditation through videos. Okay. So they must make about 30 to 40 videos, and we train them how to make the videos and how to make. So, and in some places where the internet is not so very good, we are thinking about doing half. So the local surveyors will come there on a health procurement with COVID. So one surveyor will come and do, and the people do virtually on the back. But we haven't do that yet, because until now we still can do everything virtually. If we can, if the internet is good, we can do Zoom. I think we use Zoom is the best. We use Zoom everywhere, but in some places we combine Zoom with WhatsApp video.
Okay.
Thank you.
All right. Thank you. And Australia, Michael or Lena, what's your take on this?
Sure.
Pandemic?
I think I think adding on to what everyone said in terms of being prepared for change and change in the future is also what we've learned from this is that our organizations need to be agile and flexible. You know, the market has changed quite rapidly around us, and the environment in which we work has changed quite rapidly. And just like our healthcare providers that we accredit, them changing the way that they operate, us understanding that we have to be much more flexible and adaptable in the future. So if another pandemic or another environmental change in the market hits us, like COVID has hit us in the way that we have to go from a traditional model of on-site to hybrid or virtual, being able to have the structures internally to instantly turn those on, to continuously provide the best service to our members, and also to ensure the safety and motivation and care of our staff internally.
Thank you. So Taiwan, Dr. Prof. Wang.
Okay, so I think the pandemic has changed the definition of the globalization. So I think all the stakeholders and we as a society, we need to work more closely, because if the world is not safe, we are not safe. So we need to work together more closely. Okay?
Thank you. I think that is a very good message, that we are not safe until the world is safe.
Yes.
All panelists, ladies and gentlemen in the audience, I thank you very much for your taking time off to attend this webinar. I'm sure you will agree many useful lessons have been learned by all concerned, whether it's the panelists or the audience. The world has changed because of the COVID pandemic. Healthcare system has changed, and we have to change. We have to be safe. So in concluding, I would like to thank all the panelists, and I would especially like to thank CAHO for having co-hosted the ASQua webinar with us and done all the organizational background work, without which this would not have been possible. There were many questions to which we could not provide an answer at this juncture, but we will try and respond through email, and we will try and distribute the questions to some of you, the panelists. And if you can respond by email to some of them, I think that will help in the learning process. So thank you, all concerned. Keep safe.
Thank you very much. Namaskar.
Thank you.
Thank you very much.
Thank you.
Thank you.
Bye.
Namaskar.